So without further ado, I'll go ahead. So it's primarily hematooncology. Okay. Any questions that anybody has at the moment, please let me know. Okay, so try to make it more interactive, and I'll ask question in between very quickly and see whether it can actually give you guys can come out with quick answers. I hope you can hear me properly and you can see all the slides in full. There might be some bits of the slides which might not be coming into the focus. That's because the slides are going out of focus because of its size, but please forgive me for that. Classification of hematological malignancies, as I said, cell of origin. So we can actually classify how we look at hematological malignancies. Either we can look at the hematological malignancies as cell of origin, whether it's a myeloid or a lymphoid, or we can actually also divide them or classify them according to the presentation, how they present, whether they are presenting in a very acute fashion, in a very stormy fashion, or whether they are a very indolent in an insidious fashion. So if you like to think about cell of origin, we have got talking myeloid and lymphoid. So we have got in myeloid, we have got acute myeloleukemia, which I'm sure you guys must be quite familiar with this terminology, acute myeloleukemia, AML. And that has got myriad of subsets or sub classifications, and there are many classifications on AML from the previous one, which is FAB, French American British classification, which is based mainly on morphological findings, to a WHO classification, which has got various subclassifications. And then we have got in myeloid, we have chronic myeloprolific disorders. That means chronic myeloid issues like myeloproliferative neoplasms, which are clubbed, which is an umbrella term to be used for essential thrombocythemia, ET, polycythemia rubra, and myelofibrosis. And they're clubbed again under one terminology called MPN. And then we have got another chronic myeloprolific disorder, chronic myeloid leukemia, CML, which is not clubbed under MPN heading. And then we have other dendritic cell neoplasms, which are much rarer, and I don't think we are going to go into that. And then we have got other cell of origin, which is lymphoid, that is lymphocyte, and its other cells which are related to lymphoid, like plasma cells. So in that, again, we have got acute lymphoblastic leukemia, which is again acute presentation, and then we have a chronic presentation, which are lymphomas. But in lymphomas also, we can have acute lymphomas and more insidious low-grade lymphomas. We'll talk about them in our next lecture of the same series. And in the chronic, we have chronic lymphocytic leukemia and the low-grade lymphomas. If you talk about the presentation, I think I have already covered acute presentation. We have AML, ALL, diffuse large B-cell lymphoma, and myeloma. Myeloma can be indolent, as well as it could be quite stormy, presenting with massive bone fractures and organ damage in terms of acute renal failure. And then we have chronic CLL, hairy cell leukemia, myeloproliferative disorders, like we already discussed in the cell of origin, low-grade lymphomas, and MGUS, etc. So we will talk about each and every entity at length. So what I have done in this lecture is try to create some fun in terms of discussing these around the case, so that you can relate these conditions in a more clinical fashion, and then you can start thinking about a patient who could be pitching up when you guys become Foundation 1 students, doctors, or SHO during your training. I would like to say one thing which I always say in my lectures, that each and every line of my lecture could be an MCQ for your exam. So I love to teach exam-oriented stuff, because exams, there is a stressful situation, and you need to pass these exams. So please note down whatever I'm saying and teaching today. So that is a cartoon of normal hematopoiesis. and malignant counterparts. So we have got a blood stem cell, and then it then differentiates into myeloid stem cells and lymphoid stem cells, and then these myeloid stem cells then grow or differentiate further into the red cells, myelocyte or myeloid series, and platelets. If they are chronic or they are slow to start with, they become myeloproliferative neoplasms, and if they are acute, they can become leukemias. And then we have got lymphoid, then we have got lymphocytes, which are primarily B lymphocytes, and then T lymphocytes and natural killer cells. And these B lymphocytes, when they happen to entertain or challenge an antigen, they turn into memory cells, and that becomes plasma cell. And then we have got a plasma cell neoplasms, which are myelomas. Fantastic. Right. So let's start with this case 1 study. I'm not able to. Sorry. Okay. So a 65 years old male, previously healthy, presents to A&E with bleeding gums. He's got some skin bruises and he's extreme lethargy or tiredness for about 3 weeks. He has got shortness of breath for about a week and some fever. On examination, he was found to have gum hypertrophy, which you can jolly well see on your screen. He has got large skin bruises, and because of his this bleeding and not looking good, and his temperature is high, they did a blood test. They found hemoglobin of 84, white cell count of 110, platelets 23, clotting was normal, creatinine was particularly high at 155, and he had deranged liver function test. As you can see the picture, he has got infiltrative gum hypertrophy. It is not a bad hygiene. It is just, of course, you can see his teeth, which are not very clean, but you can see there's a clear overgrowth of the gum, and it is a gum hypertrophy. Any idea what this condition could be? You don't need to raise your hand, just speak up. It doesn't really matter who speaks first. Anybody can unmute and just say what you think it could be. What is happening here? Hemoglobin is low, platelet is low, white cell high. So what is happening here? Anybody who can come out with a bright answer, and then we can give him some kind of a chocolate. Anybody? I'll give 5 seconds at the max. If you want to actually switch on your mic, you can switch on your mic as long as you don't have any background noise. Okay, so it is a gum hypertrophy, and what would be alarming here is that he has got some skin bruises. That's fine. It could be something else. He could be on aspirin. He has got some tiredness, and he has got some fever. So there are 3 things which are telling you that 3 cells lines are affected: the red cells, the platelets, and the white cells. And then you did the blood test. You found that he has got low hemoglobin, anemic, and his white cells are exorbitantly high, and his platelets are low. Clotting is normal, and he's got renal impairment, could be acute kidney injury, and his LFTs are not good. So you got alarmed that there is something really bad going on in his blood. He's got very low platelet count and very high white cell count. So you did a lab diagnosis. So whenever there is an abnormal blood test, the lab technicians, they actually make a blood film looking at the what you call Coulter counter report, which is an automated report, and the automated report does flag any abnormal cells. So it will tell you how many neutrophils are there, how many white cell count, and how many platelets, and how many abnormal cells are there. So it will flag, and that flag will be picked up by the technician in the lab or the lab scientist, and they will make a blood film. And this is the blood film picture. These cells are not looking good. They are looking very abnormal. And, well, basically, we don't know what they are. They're large cells with very large cytoplasm, nucleus looking horrible. It looks very open, and it has got large globe, kind of blister-like things in the nucleus. And these things are nucleoli, and he has got large cytoplasm. So there is thing called as nucleoplasmic ratio, which is not high in this case, but it is still deranged if you think that these cells could be lymphocyte, but what kind of lymphocyte these are. So they're looking abnormal, right? And there are quite a few. All of them are looking similar. So it means whatever white cell count we are seeing, they're all like these cells. So the normal white cells count are not there. They have been replaced by these abnormal cells. And then we did a bone marrow. We found that bone marrow is largely replaced by these abnormal cells, and they're called kind of a mononuclear cells, and they are quite monotonous. We can't see any normal myeloid series. So you have got red cells in the background. That's fine. Oops, that's fine. But then we have got these cells which have got very abundant cytoplasm, and we have got no any granules in them, which is generally seen in a myeloid cell. The cytoplasm is rather, although it looks bluish, but we call it as pale cytoplasm. It is not that blue, which could indicate something else. And the one thing is that it is replacing the whole bone marrow. So there is a clonal infiltration of the bone marrow by these nasty cells. So this is what you call as acute myeloleukemia, M5. I'll tell you what M5 means, but in the terminology, it is a monoplastic leukemia. So whatever you're looking at were monoblast. And if you go back to your what you call cell pathology lectures or pathology lectures, sorry, what you call histology lectures, which is a normal histology, you would remember how a monocyte looks like. So a monocyte looks like a abundant cytoplasm, slightly a very pseudopodic nucleus, and abundant cytoplasm, and practically no nucleoli. But in this case, it was not pseudopodic. It was rather a bland-looking nucleus, and a cytoplasm was rather abundant. And the size of the cell was also big, and there were nucleoli. So it did look like a leukemic cell. Now, what the problems are in this patient, why this patient is in real trouble, that we need to ascertain. And that's how we need to be very careful about this patient, that we need to act fast, quick enough. Otherwise, this patient can be in a major problem. And I'm sure that you will appreciate, even though you're first year or second year or whichever year you are in your medical training, that the white cell count is rather high. So high WBC is a major problem because they're large chunky cells. So if you get large chunky cells and at 110, what they will do, they will cause hyperviscosity in the blood. It will go and clog the kidneys. They will settle in the lung, and that's causing shortness of breath. And then it will also, when they will die with a lot of debris behind, and that will be even more disastrous for various metabolism and various organs. So this patient is particularly, so as I say, I have written here, it's the single most poor prognostic marker in AML. So if you have got an AML who's got a white cell count of above 100, it's a single most poor prognostic marker to present with. Okay. And then, of course, unless we treat him quick enough, this patient may have an established renal impairment, might need dialysis, and he might also go on a ventilator because his lungs are going to be infiltrated by these monoblasts. And he will have Tumorizes Syndrome. So I was talking about the FAB classification, French, American, British classification, which is primarily based on the morphology, which is still being used, although it is rather obsolete, but it is still being used because when we look at it in the microscope, that's the only thing we can actually think about, and we can start making our assumptions that this looks like M1 or M0 or what. So M0 to M7. So M0, when the myeloid cells have got minimal differentiation, that means it has not even decided whether to go to the lymphoid side or the myeloid side. And then we have got M1, which is AML without maturation. That means it has differentiated, but it has not started to mature. So it has committed itself to become a myeloid cells as it grows, but it has still not shown any maturation. And then M2, when the cells tend to start maturing. I know that you can't see those cells. The picture is rather fuzzy, but the take-home thing is that's how, according to the maturation and differentiation, we do. The take-home message again in this slide is M3 is the AML M3 is something very specific, and we'll talk about it later on. And then M6 is a erythroid leukemia. That means that is coming from erythroid red cells leukemia. And then M7 is a megakaryocytic leukemia, or a megakaryoblast leukemia. That means it is coming from the platelet or megakaryocytes. So in terms of the diagnosis, what we do for AML, if we have a blood test, so first and foremost thing is that we have to be very, very prompt. We can't sit over it, and we can't actually take our decision in a very kind of a slow fashion. We have to act fast. We need to do the investigations. So if the white cell count is very high, we can actually do a test on the blood film or the blood on the peripheral blood. You may not need to do a bone marrow. But of course, the bone marrow is the gold standard. Then you do the bone marrow, and the bone marrow then what are the tests which we'll do? So in the bone marrow, we will look at the blood film, we'll look at the bone marrow morphology. So these are the two morphological. So just note down what all we are doing here. We are looking at the peripheral blood. So first and foremost thing is, if an AML patient walks through the door, look at the blood film and start making assumption that whether it is AML or ALL or something else. Or if it is AML, what out of the FAB classification M0 to M7, what it could be. And then do a bone marrow to further classify. And in the bone marrow, do the test like immunophenotype. So immunophenotype is testing by which we check the cell of origin, whether it's a lymphoid, myeloid, and if it's myeloid, at what stage of myeloid, according to the cell antigen it is expressing on its surface. We mix the cells with antibodies, monoclonal antibodies, and then mix it with some color, and then pass it through the laser technique, laser machine, and that laser machine will throw the cells into different areas of the graph according to its antibody it has picked up, according to the size of cells into different graphs. And then you pick up, okay, this is a granulocytic precursor, this is the blast area, so that means there are a lot of blast, and so on and so forth, right? I don't need to actually go into that detail. It is beyond your remit at the moment. And then on these cells, we do karyotyping. We check the genes, whether there are any translocation in the genes, whether one to another, and et cetera, et cetera. And that will tell us whether, you know, this what kind of leukemia it could be. And then we do the mutation analysis. The cytogenetic could be normal, but there are some mutations, the genetic abnormality in terms of the mutation. And the two most important mutations in AML, you would like to note it down, is FLT3, FLT3 mutation, which is a harbinger of poor prognosis in AML. So these are the tests you will do, and also you'll do a trophine biopsy. That means of the bone marrow. When you come to the hospitals, or you go to your respective hospitals, you go to the hematology section and see how the bone marrow is performed. I will strongly recommend that. So this is the this actually tells you. So you could find an MCQ following. One of the following is not a test to be done for diagnosis of AML, and there will be a list of all these things, and there will be something else. So I'm just telling you that this could well be an MCQ for your exam. So if you look at the myeloid, how the myeloid matures, so you have stem cells, go to myeloid progenitor, and then you have got CFU, the colony forming unit. That then we have that differentiates the myeloid, the megakaryocyte, the monocytes, and erythroid. So look at this. When I take the lecture face to face, I always draw these cells on my flip chart and tell you how a blast looks like. So you will have these starting cell as blast, and then it turns into promyelocytes, then actually becomes a bit granular, the nucleus becomes smaller, and then it loses nucleoli. And then you have got myelocyte, where you have got more granules, the nucleus becomes even smaller, the size of the cell becomes smaller, and then it loses all the nucleoli. Then it has metamyelocyte, when the nucleus has started to take some form of shape, and then it becomes a band cell, and then eventually the neutrophil with segmentation of the cell. So in the AML, the blast percentage should be more than 20%. Can you note it down, please, as a question, as an MCQ? So you'll get what are the blast percentage for definition of AML? 20%. Normally, in a bone marrow, you should not have more than 5% blast. Another question to note down. Fine. So these are the tests you'll do. The classify now the WHO classification of AML is by cytogenetics, if it has previous therapy, which is called as therapy-related AML, and then we have whether it has got a background of myelodysplasia, which is Myelodysplastic Syndrome, and also degree and type of maturation. You don't really need to go into the detail of that. You can look at the WHO classification of AML if you want to, if you think it would be relevant for your exam. This is something about, the incidence of AML. As you can see, the incidence of AML grows with age, and you can see majority of the patients are above 60. So in the UK, there were, in a year, there are about 3,000 cases in the country, and then that is 1% of the population does get AML, so it's about 1% per 100,000. The median age of acute leukemia is about 60, and the incidence has been gradually rising. Please don't forget to ask questions in between. I'm not looking at the comments unless Harup or someone is actually looking at it, and they can inform me that there is a burning question. So how do these patients present? And I have given a case scenario that this patient generally present very, very fast, within a few weeks. So 4 or 5 weeks ago, they were absolutely fine, there were no problem. Bang, something happens, they started to feel lethargic, they start to have bruising, and they might catch infection. So anemia, fatigue, fever, infection, bruising, bleeding. They may or they may not have hepatosplenomegaly. They may have lymphadenopathy, according to whether it's ALL or it is AML. And very, very rarely, the patients can have CNS infiltration with AML. Family history is generally not seen, and it doesn't really tell you much about the genetics of AML. Principles of treatment. AML is treated with combination chemotherapy. It's a fairly dreadful disease. We need to start acting on them quickly. Repeated courses of chemotherapy for ALL, which we'll talk about length in the second lecture of the series. But let's concentrate on AML. It's a combination of anthracycline and purine analogs like doxorubicin and fludarabine. And then the mainstay of the treatment is allogeneic transplantation, because the prognosis generally is poor. It's a poor prognostic disease, and it does have relapses, frequent relapses, unless you do a bone marrow transplantation. We have talked about treatment and MRD testing, how we actually follow these patients up. So one important thing, and you will be quizzed on AML, on Tumorizes Syndrome quite often in your clinical practice and also in your MCQs, it is Tumorizes Syndrome. So what actually happens is that because these cells are big, these cells are too many, when they are killed or they kill themselves, they will start to leave a lot of nucleic acid debris behind it. Okay. So the cellular component is released into the cell, and after chemotherapy, and it can cause a lot of cell leakage of the nucleic acid residue. And what actually happens in this cartoon, you can see what happens is that the most important cell, which actually is released after the cell death, is potassium. So you are having a massive amount of cell death. You can see there's a cellular breakdown, there's a release of DNA, and then you have a catabolism of the purine and of the purine from the DNA, and there is a production of uric acid from that, which uric acid can damage the renal tubules, which can in turn causes in turn cause acute renal failure. The hyperkalemia, because of the cell death, can immediately cause neuromuscular irritability, causing heart arrhythmias and cell death, and the patients can die with that. So the most important thing, hyperkalemia, it can kill the patient immediately with heart arrhythmias. Acute renal failure will be a massive problem because it can cause patients established acute renal failure requiring lifelong dialysis. Hyperphosphatemia is also there, but there's less of a problem. So you've got to be very careful about Hemolysis syndrome, how to manage it. And how we manage it, of course, you can imagine you have got a lot of debris of the cells. You like to give lots and lots of fluids, hydration. And then you give something to either destroy the nucleic acid, the uric acid, or you give something to retard the formation or production of the uric acid. So there are two main drugs, and again, you'll be quizzed, so please mark it down because these would be definitely an MCQ for you. So there are two drugs. One is called Allopurinol, which is a xanthine oxidase inhibitor. If you can see the series here, there's a purine catabolism. Hypoxanthine is produced from hypoxanthine xanthine, and then xanthine is converted into uric acid. So how allopurinol works, it actually stops the conversion of xanthine into uric acid, but it's a slow process. The uric acid has got a slow solubility, and it can actually clog the kidneys and cause renal failure. So this is one drug. So we tend to, because it's a slow process, we tend to give allopurinol, in which we have less tumor burden or less cell burden, like low-grade lymphomas or low cell count AML. But in the patient who have got white cell count of 100, you would like to give something called rasburicase. The rasburicase, how it works, it is a urate oxidase. So it's an enzyme. It is not an enzyme inhibitor, but itself an enzyme. And what it does, it actually dissolves uric acid into allantoin, which is highly soluble, and it can be easily excreted in the urine. So important thing for you to remember, and please make sure that you read Tumorizes Syndrome, because you'll be repeatedly quizzed on this one. Now let's talk about the case 2. So there's a 43-year-old female, previously healthy, presented to A&E, lethargy for 3 weeks, bleeding gums and bruises for 2 weeks, and she's got headaches and blurring of vision for 2 days. So you must make sure that you notice each and every part, each and word of what I have presented, right from the sex of the child, of the patient, to the age of the patient, and how they're presenting. Everything has got a relation with that particular condition. So here it's a female, here it's a youngish patient of 43, right? And this patient is now presenting with headaches, right? So the blood test shows hemoglobin is low, white cell count is low, platelets are low. So what is it called? It's called severe pancytopenia. She's got neutropenia, neutrophil count is low. The clotting screen shows that prothrombin time is raised, INR is 2.3, APTT ratio is raised at 1.8, fibrinogen is low, and D dimers are stonkingly high. So this patient has got a picture of a terminology called as disseminated intravascular coagulopathy, DIC. Okay, because patient has got deranged, both the tests, INR and the APTR, both are raised, and low fibrinogen, and the D dimers are high. Okay, so again, make sure that you understand and note down what is being taught in this lecture. Everything is important, and it will be an MCQ. I'm reiterating this. So what's happening here? A young lady with headache. Why I'm saying headache? Anybody can quickly say why headache is important? Anyway, so and the patient has got coagulopathy, right? So on the blood film, that's what we saw. We saw that this patient has got rather abnormal cells. They are bilobed. They are granules, but they are concentrated on one side, and rest of the cells are not even granular, so they are hypogranular. So they are called hypogranular bilobed promyelocytes. These are abnormal myelocytes. And I'll tell you a very important thing, that this is extremely important for you as a registrar or a consultant to look at the blood film immediately on any AML who has presented with coagulopathy, i.e., DIC-like picture, because it could be this condition, which is called as acute promyelocyte leukemia, AMLM3. The reason is that these patients can die very quickly because of the coagulopathy. They can have massive intracranial hemorrhage, and these patients are practically become unsalvageable. The second thing is that if you act fast enough, these patients can live forever. So do you understand the reason of your quickness as a consultant or a registrar to look at the blood film, take a decision then and there that this looks like APML. If I don't act fast enough, I can lose this patient next morning. So you can see this is a CT scan, and it is a massive intracranial hemorrhage, which we always suspected. So remember, headache, patient had headache for the last 2 days. So you should really get very suspicious that it could be acute primary leukemia. If you do a bone marrow, you see lots and lots of these promyelocytes, and these tiny needle-like structures are R rods, AUR rods. These are the collection of granules, abnormal granules, and these are abnormal cells. The other characteristic thing about this condition is that it has got characteristic 15-17 translocation. So there's a translocation between the chromosome 15 and 17, which gives rise to an abnormal protein called PML-RARA. So promyelocytic and retinoic receptor protein, and when they join together, they do what you call as arrest of the maturation in promyelocyte, and that causes further neutropenia, and these patients then become cancerous. So 15-17 translocation, PML-RARA, our rods, abnormal promyelocytes, DIC, these are the characteristic feature of APML. And what's the other thing I told you? It could be poor prognostic if you don't treat fast enough, but it could be very good prognosis. In fact, the best prognosis in AML if you treat them fast enough with a drug called ATRA. Okay, so this is just about the pathogenesis. So there's a translocation between 15-17 translocation, and then differentiation arrest happens and the cancer happens. So it is the few characteristic features which I have already told about, so I don't need to repeat this slide. The effect of ATRA, so all trans-retinoic acid, ATRA is very important in terms of saving and salvaging these patients. The moment you see these promyelocytes on the blood film, you must start the patient ATRA straight away. Even though it might be 2 a.m. in the night, you would call your pharmacist and start the patient on ATRA. So what ATRA does is basically ATRA and arsenic trioxide it results in degradation of the PML-RARA fusion protein and release of the co-repressors, and then it allows the normal maturation of the promyelocytes into the mature granule site. Okay, and when they mature, there's a less chance of coagulopathy, because coagulopathy happens because of the release of various cytokines from the granules of promyelocytes. So what we need to do is to push these abnormal promyelocytes into the mature neutrophils to prevent the happening of DIC. Prognosis is extremely good of APML with the ATRA and also arsenic trioxide. You also add some chemotherapy, and these patients would not need a transplant. These patients can be cured forever. It's a very high cure rate for these patients. Case 3. Any questions till now? Are you all guys happy with the speed? And am I going too fast? I'm happy to kind of slow down because there are lots of slides to go through. Everybody's okay? I'm not looking at the comments because it will slow down my Haru, are you okay with that? Okay, someone is actually giving diagnosis. Oh, excellent, very good. Right. What I'll do is to give you ample amount of time to ask these questions because I'm not looking at these comments at the moment. Case 3, 70 years old male, previously healthy, presented to GP, lethargy for 3 months, mild bruising and occasional nosebleed for 2 weeks, recurrent infected sebaceous cyst requiring multiple courses of antibiotic. Fine, so what is happening here? This is a 70 years old male, fine, so kind of elderly, previously healthy, lethargy. So it is insidious, it's an indolent presentation. It's not like 3 weeks. He's been unwell for 3 months. He has got mild bruising and occasional nosebleed for about 2 weeks. So what is it telling? That things are gradually progressing. And then you have got recurrent infection. So that means there is a red cell affection, there is an affection of the platelets, and now the white cells are also getting affected because this patient is having a recurrent infection, but not severe infections, some kind of a skin infection, a sebaceous cyst. And the blood test shows that it has got pancytopenia with low hemoglobin white cell neutrophils. And what is spectacular here is the mean cell volume. The MCV is high. So please note it down that this is important. And what I have written here, the vitamin B12 and folic acid are normal. So one of the commonest causes of macrocytic anemia or macrocytosis is megaloblastic anemia, which is because of the vitamin B12 and folic acid abnormality or reduction. So that is normal. So that means we have ruled that out. So why the MCV is high? So this condition, which I'm going to describe, is particularly it presents with high MCV. What happened? Yeah, okay. Right, so look at the blood film. Oh, what are those bespectacled cells? Yeah, so these are actually neutrophils, but there are two things which are abnormal in these two cells, that they hardly have got any granules, right? We can't see any granules. And neutrophils generally is a multilobated or multi-segmented cell. And this one, it is only showing 2 segments. Yeah, so it is a hypogranular, hyposegmented neutrophil, or it is also called as pseudo-Palgohair. Yeah, pseudo-Palgohair abnormality. So Palgohair abnormality is a congenital condition, but this is a pseudo-Palgohair. That means it's not congenital, it is an acquired condition. That's the reason it's called pseudo. So that gives you an indication that this is not right. And then in the background, the few of the red cells are not looking normal shade. Like this cell is looking odd. There is a new cell generation because of anemia. This red cell doesn't look right. This cell doesn't look right. It's elongated red cell. So these are not looking happy cells. So something is grumbling. Some unhappiness is going in the bone marrow. And we did the bone marrow. We see this large cell, which is actually a precursor of the megakaryocyte. But what is abnormal in this cell? It is monolobulated. It has got only a single lobe. Generally, the megakaryocytes have got multiple lobes. And then we see that the rest of the cells are also not looking to be normal. They're not looking blast. They're not cancerous. They're not leukemic, but they're not maturing normally. Look at this red cell. It has got bilobes, right? And the cytoplasm is fading away. So it is actually going into that kind of a cell. That means it is about to come out in the peripheral circulation. And before it actually comes in the peripheral circulation, it should have lost the neutrophil. It should have lost the nucleus. But what's happening here? It has got rather two nucleus. So that's absolutely abnormal. Yeah. So these cells are not looking normal. There is an abnormality going on. So this condition is called as Myelodysplastic Syndrome. So there's a dysplasia of the bone marrow. Dysplasia is when the cells are not maturing, and it's an MDS. It's a pre-runner to acute myeloleukemia. Okay. And this is characterized by bone marrow failure with resultant cytopenia and related complications. And it has got clonal cytogenetic abnormality, and it has got tendency to progress to acute myeloleukemia, and overall incidence about 3 to 5 per 100,000. Median age is about 70 years. Okay, and this is the scoring system for how we grade the severity of the disease. So we look at the cytogenetics, we look at the bone marrow blasts, how many leukemic cells are there, we look at the hemoglobin representation, platelets and neutrophils. So these are the 5 things we look at to grade the severity of MDS. So anything which is very low, of course, has got a better prognosis as compared to a very high, which is going to have a poor prognosis, and these patients would need to have a treatment. So WHO MDS classifications, how we classify MDS is by progression of the disease. So we can have just refractory anemia. That means the patient is just anemic, right? The platelets are fine, the white cell count is fine, but this patient is anemic. We do a bone marrow, we don't find any blast, increased blast cells or leukemic cells, and there is no other cytogenetic abnormality. So this is just a refractory anemia, so MDS-RA. And then we have got abnormal metabolism or assimilation of the iron granules in these cells, and that condition is called refractory anemia with ring sideroblast. So there is a circulation or encircling of the nucleus by these abnormal cells, abnormal granules. In fact, it was there in the bone marrow, so you can see that these there's an abnormal circulation or encircling of the granules, the iron granules. And then we have got refractory anemia with multilinear dysplasia. That means all 3 lines have got dysplasia. They are not looking at normal. And then we have then starting of the excess blast, which is 5 to 9%, which is called type 1, RAEB type 1. And then we have got RAEB type 2, which is 10 to 19. And if you remember the definition of AML, anything above 20 or 20% is AML. And then we have got MDS unclassifiable, where you know that we can't kind of explain it by anything. And then we have got MDS with isolated deletion 5q chromosome abnormality, which is generally a better prognostic condition. MDS treatment, if it's a very low score, you just observe the patient, don't do anything. If it's intermediate, we can give growth factors like GCSF or erythropoietin. It's high to very high, then we can give hypomethylating agent or give AML-like chemotherapy and then transplant by allogeneic method. Case 4, so 32 years old, South Asian male, right? So as I said, please note down every word of this presentation. Young man, South Asian origin, presented to the GP, extreme lethargy for about 3 months, bruising, gum bleed for 3 weeks, intermittent fever for 2 weeks. Blood results, hemoglobin 75, white cell 1, MCV normal, neutrophil 0.2, platelet 20. So severe pancytopenia is going on here. White cell count is only 1, neutrophil 0.2. That's very dangerous. Clotting screen normal. Reticulocyte count is low, right? So reticulocyte count, reticulocytes are the precursors of red cells. So when you have anemia, the bone marrow tends to produce the new red cells, and they are like infantile red cells, and they that is called reticulocyte count. So when the reticulocyte count is low, that means the bone marrow is not able to produce or not able to compensate for anemia. Okay, so that it shows that the bone marrow is rather sluggish or maybe empty. Vitamin B12, ferritin, and folic acid, all three are normal. We did the virology and we found this patient has got hepatitis B core antibody positive. And so we have noted down a few things. Is in South Asian male, it's a young man with severe pancytopenia. Clotting is normal, right? And the blood film shows severe pancytopenia. So there are no leukemic cells. There are no blasts. So it's not leukemia. So we did a bone marrow. So we found that this bone marrow is rather empty. You can see no, lots and lots and lots of fat spaces, but where are the cells? Nothing. This is a normal bone marrow, so what it should look like. Fewer fat spaces and a good, healthy production of the cells. But here we got nothing. It's a hypocellular bone marrow. So remember that this is, aplastic anemia. So would you remember that? Young patient, I mean, it could be old also, but, and South Asian. So it is the incidence is far more in South Asia or Asian countries or Far East as compared to the Western world. The Western world aplastic anemia is very low. It is associated with toxins. It is associated with infections, or it could be idiopathic. Even idiopathic aplastic anemia is commoner in Asian population than in the Caucasian. So these are the causes of aplastic anemia. You can remember it by an acronym of Lionel-Messi: long-term exposure to toxin, ionizing radiation. Then we have got thymoma, pregnancy, graft versus host disease, nocturnal hemoglobinuria, which is paroxysmal nocturnal hemoglobinuria, Epstein-Barr virus, lupus erythematosus, or any autoimmune condition can also cause aplastic anemia. Then we have got medications. Things like anti-thyroid drug, carbimazole, and it could be an MCQ to you that carbimazole can cause aplastic anemia. And then the anti-epileptic drugs can also cause aplastic anemia. Then other leukemic processes like Myelodysplastic Syndrome can do that as well. And as I said, hepatitis is a very common cause. And then we have got congenital conditions like Diamond syndrome. These are inherited bone marrow failure. And the important thing is the idiopathic. And this is the scheme of things for aplastic anemia treatment. If you have got someone who is younger than 40, and if you have got a donor, you should not waste time and transplant this patient. If you don't have a donor, then try the anti-immune therapy or immune suppressions like antithymocyte globulin or cyclosporin, and then maintain them if there's a response. Then maintain them on ATG and CSA. And then if you have patients above 40, then straight away you should do ATG and CSA with GSF or growth factors. And then depending on how you get the response, either you can further proceed to the transplant, or you can try other novel therapies for aplastic anemia. Case 5. So 75 years old male presented to GP with ringing in his ears for the last 3 months. So what do you call ringing in the ears? Called tinnitus. Okay. He has got tingling and numbness in the fingertips about 2 months, blurring of vision for about a month, constant headache for 3 weeks. So things are gradually progressing here. And we did the blood test and we found hemoglobin was 164, which is slightly on a higher side, WBC of 11, platelets of 784, and potassium of 6.7. So can someone quickly say why I put values of potassium out of blue? Why I'm thinking about potassium? Certainly, I'm not talking about creatinine. I'm not talking about sodium or calcium. Why I'm saying potassium? Yeah, someone is putting something. TLS, no TLS, no, it's not TLS. It's not hemolysis, no hemolysis, no. Yes. Few more guesses. TLS, no, it's not TLS. Okay, fine. Polycythemia. No, I'm saying why potassium? Why I'm saying good. Someone has got a diagnosis. Right. So it is a platelet. So the platelets, when you have got high platelets, on a kind of a TLS, you can say. So the platelets will actually leach out a lot of potassium. So it is a it is nothing too much. It is nothing to worry about. Okay, we don't need to really act upon it unless the potassium really is high. So okay, beautiful blood film. Look at the blood film. So what is happening here in the blood film? There are bunches and groups of these tiny platelets everywhere, right? So many platelets. And then we have got, what is this? This looks like a red cell, but it is actually a giant platelet. Yeah, and again, lots of platelets around. So giant platelets is a hallmark of essential thrombocythemia or high degree of platelet count. So what's the diagnosis? Essential thrombocythemia. And symptoms, the patients could be incidental, they could be entirely asymptomatic, right? And then they will have lethargy, they will have headaches, because you can imagine there's so many platelets, they will be clogging and slowing down the blood circulation. So you will have something like hyperviscosity, you will have tingling, visual disturbances, tinnitus, and in a severe case, you can have thrombotic events like stroke, myocardial infarction, DVT, pulmonary embolism, and you can also have mild splenomegaly. This is a diagnostic criteria for essential thrombocythemia, that the platelet count should be more than 450. The bone marrow biopsy should show a typical kind of hyperlobulated megakaryocyte, and that should be a proliferation of those kind of cells. And then you should have a JAK2 positivity, and the JAK2 positivity is seen in about 60 to 70% of essential thrombocythemia patient. And you should not have reactive cause of thrombocytosis, and also there should not be any other clonal abnormality. So if you talk about how we treat essential thrombocythemia, it can be risk stratified as to how we treat these patients. So if you look at the high-risk patient, so who are the patients who are absolutely requiring treatment? So if you have got previous thrombosis or a bleeding, regardless of what your count is, you must go for treatment. If you are above 60 years old, regardless of what your platelet count is, you should go for treatment. And if you have got nothing of the previous two, but you still have got a high platelet count above 1500, you must start the treatment. The treatment for these patients is cytoreductive treatment. So that means you need to give something to reduce the platelet count. And the most important drug is hydroxycarbamide, which is very low side effect profile drug, easily tolerated. You can easily give it. It's a tablet. And if you have got patient who's younger than 60, then you can give things anagrelide or pegylated interferon. The reason is that hydroxycarbamide can cause cancer itself, because it's an anti-cancer drug. So if you give it for long term, it can cause cancer. The younger patient may not like to have it, or you may not like to give it to them. So we give drugs which are not supposed to be anti-cancer. And if you have got, if you don't have any of these things, then risk stratify these patients. Intermediate risk, where the platelet count is not above 1500 but is still high. Patient is not above 60 years old. Patient has got CV risk disease factors. Patient had previous myocardial infarction, or diabetic or hypertensive, but no bleeding or thrombosis history. In these kind of patients, if the patient is above 60, you give hydroxycarbamide, and if less than 60, then you give interferon. If there's low-risk disease where you have got none of these, and the platelet count is less than 1500, you just watch and wait, and you might give some anti-platelet drug, aspirin, if the platelet count is, high. So this is how we treat ET. Case 6, so 53 years old male presented to A&E with left-sided hemiparesis. CT scan showed a middle cerebral artery infarction. On examination, he has got plethoric faces. So he's got very red, angry-looking face. He also complaining of headaches and blurring of vision, palpitation for about previous 2 months. There's a history of itching after shower or bath. Okay, so note down all these things. And then you do a blood test, and his hemoglobin is 210 grams per liter. The hematocrit, the HCT, is 56, which should be below 45 or 49 for a male. white cell count 12, platelets are also on the higher side of normal. And this is how it looks like. Yeah, he's got very engorged face, which is called as plethoric face. You do a further investigation, and you found that he has got JAK2 mutation, his erythropoietin. So these are investigations we tend to do: JAK2 mutation, erythropoietin levels, red cell mass, and bone marrow. So this is the criteria for PRV diagnosis. Hemoglobin in male is 16.5 and female 16, and then you have got a hematocrit of 49 and 48. You should do red cell mass and a JAK2 study. Symptoms we have already talked about: itchiness, numbness, or hyperviscosity kind of symptoms, right? So what do you do for the treatment is urgent venesection. We take the blood out like a blood donation. We bring hematocrit to less than 45. You do cytoreduction like hydroxycarbamide and interferon, and you give JAK2 inhibitors like ruxolitinib. Prognosis: 10 to 15% chance to transformation to myelofibrosis, and a 2 to 10% chance of progression to acute myeloleukemia for PRV. This is a cartoon of JAK-STAT pathway. So here you have got a cytokine signaling and a receptor which instigate the JAK-STAT pathway, and the JAK-STAT pathway then in turn causes replication of the cell. So we have got JAK1 and then JAK2. JAK1 is a proliferative domain, and the JAK2 is an inhibitory domain. So the function of JAK1 is to give signal to the nucleus for replication, whereas JAK2 is to inhibit that. So there's a problem in JAK2 in terms of inhibition, and then you have got generation of polycythemia, essential thrombocythemia, primary myelofibrosis. And polycythemia is about 100% patient will have JAK2 mutation, essential thrombocythemia 70 to 80%, and primary myelofibrosis is about 50%. Case 7, 67 years old male, presented to GP, early satiety for 4 months, weight loss for about 6 months, abdominal swelling for 4 months, night sweats 3 months, intractable itching for 2 months, and on examination his splenomegaly is 18 centimeters. Blood test shows hemoglobin of 84, platelets are rather high, and the white cell count is 16. And you get occasional blast on the blood film. And this is what the blood film looks like. So you have got these teardrop cells. You can see these beautiful teardrop cells. That's 1, 2, 3, 4, and many others. And then you have got these cells, which is, this is a basophil, and you've got a nucleated red cell sitting there. You've got a neutrophil sitting there. You've got a myelocyte sitting there, and you possibly have got a blast sitting there. Okay, or a promyelocyte. So this is what it shows, that the bone marrow is very restless and is jetting out all the cells in the peripheral blood. This is called as leukoidethroplastic blood film, and you'll get an MCQ on it. We did a bone marrow. We found that he has got replacement of the bone marrow by this fibrous tissue, and this is called as fibrosis. Yeah? And this is a reticulin stain, by a special stain by which you can check how many fibers are there, or what's the degree of fibrous replacement. So this is a condition called myelofibrosis, and this is the scoring system of myelofibrosis. This is called DIPS plus scoring system. So you check the age of the patient, whether you have got P symptoms like night sweating, weight loss, itching, and splenomegaly. The white cell count is high, hemoglobin is low, and you have got peripheral blood more than 1%. And then according to that, you have got low myelofibrosis would live up to 185 months. And then as you go up in the score, the high intermediate to high is going to be about 16 months of median survival. Treatment is by growth factors. If it's a low risk disease, then you give androgens to boost the hemoglobin, and then the first line treatment currently is ruxolitinib or fedratinib, which is a new JAK2 inhibitors. And then if you have got a young patient who's got a high risk score, then you straight away do the transplant. If the patient is elderly, you can't give much, then you just do best supportive care with transfusions, etc. So this is about the JAK2 positivity and the three kind of MPNs. As you can see in the PV, you got JAK2 positivity nearly 100% patient, and in the ET you have got slightly less percentage, and in MF you got even less. But this is a unifying diagnosis in these three MPNs, and that's the reason they have been clubbed together. Case 8, 45 years old male, discomfort on lying down left side for 3 months, mild tiredness about 2 months, and on examination he is found to have splenomegaly of 10 centimeters below the costal margin. Blood result shows that he has got a high white cell count, but rest of things are normal, and a biochemistry is normal as well. We look at the blood film, and what you see is that there are two main cells. The neutrophils, which are plentiful, these hypersegmented cells are neutrophils, and then you have got these cells, which are the myelocytes. So this is called as myelocyte and neutrophil peak. And then we have got some eosinophils, and we'll see also basophil, but I can't see in this blood film. We did a bone marrow, we did a G-bending cytogenetics, FISH studies, the molecular test for BCR-ABL. So this is a chronic myeloid leukemia. This is how it actually happens with the 922 translocation in the chromosome between 9 and 22. You get a BCR-ABL fusion gene, which then instigate the constitutive tyrosine kinase enzyme, which causes phosphorylation of multiple substrate, and then it gives rise to the CML, chronic myeloid leukemia. The treatment of chronic myeloid leukemia is by these Tki inhibitors, the tyrosine kinase inhibitors, and what it does is actually sits into the ATP domain, which is the main domain by which the cells are proliferating after the BCR-ABL meets the substrate. Imatinib sits into the pocket of ATP and does not let the effector cell to function. And that's how the disease is controlled. Now we have got further TKI inhibitors, the second, third, and the fourth generation of TKI inhibitors. We just possibly need to remember the name or just know the name. And the prognosis, because of these TKIs, the prognosis has gone beyond 10 years, and many patients are looking for cure even after stopping the drug. So, as I said, there were 60 slides, and we definitely have gone, beyond the time.